Okay. Hi guys. I'm very happy to share this time with you because I think that we are discussing during these sessions a very important topics. Very important because I think these topics will be the background, an important background for your life, for your medical life. Yesterday with Professor Ineburger told us about chronicity. Chronicity, I would like to make some comments on chronicity because yesterday we didn't have enough time. First, we are part of the same team. Me, Dr. Ineburger, Dr. Buzzi, and many others, and those who you are using to work in team and to discuss cases and to share results and to improve lives, quality life of their patients. This is very important because this is a thing, I think, also an ethical lesson. It's not important to be a very good surgeon. It's important to be a good surgeon, but to share your results with other people who can work in team with you. For example, oncologists and pneumologists and many other specialists. Why? Because yesterday when you answered that your target is to be surgeon more than general practitioners, I was really impressed. To be general practitioner is to be the coordinator of a group of people. It's a theoretical. I understand why you don't like in your vision it's not so good to be a general practitioner, because in your vision the general practitioner is someone who used to write prescriptions, but it's not like this. For example, in other countries there is a very interesting study on it. For example, we have general practitioner in Germany, in France, who are coordinator, and this is important. It's important because we have, when we discuss on chronicity, we have some keywords. We have causes, outcomes, quality of life, freedom of care, and creativity. The same keywords, we can use exactly the same keywords when we discuss on coma. We discuss on post-coma. I'm really I use happy, but it's not happy. I'm so sorry. This is a very difficult day for me today, but okay, no problem. I would like to introduce you Dr. Buzzi. Dr. Buzzi came for she's a low-profile doctor. Low-profile in the sense that she doesn't like to talk a lot of her medical life, but she came from Harvard Medical School. Okay, the dream of a biggest part of doctors. She spent 10 years of her life in Harvard Medical School, and she decided, as a lot of Italian people, to go back to Italy. I don't know if now she is very happy on this decision, but anyway, she decided. Then I think that she will talk with you on different problems. First, she will introduce coma. What is coma? Because it's important for you to have a definition of coma. And then which kind of behavior we can have the patient, the family of patients, and all the people around the patients have to have when you have in front of you a patient in coma or in a post-coma, okay? And then communication is very important. Dr. Buzzi will explain to you how it's not only a technical, something technical to treat a coma and the post-coma, but it's also a problem of communication. You need to explain and to repeat because of course, as for any kind of chronicity, because it seems strange, but a post-coma could be a long period. Then you enter, if you want, in the group of, if you want, chronicities, but it's not correct, and then we can discuss on it, but it's interesting that communication, it's a very important point. Another important point is the ethical point of view. Okay, we have discussed about the possibility, the freedom of care. Okay, what we want if it happens something. Okay, we will see a video on it from TED Talks you have seen for the first time probably yesterday, because it's important to imagine the long pathway of a post-coma period. Then Dr. Buzzi, and then thanks a lot to be here with us and to share your precious time with us, because she has a long CV. Imagine that she didn't put in her CV the publication, but just a line, please, you can check. Okay? This is low profile, and then it's a clear way to show that she doesn't need to explain more. Okay? Thanks, Dr. Buzzi, to share your time with us.
Thank you for the nice introduction, and I just want to answer the question why I came back from Harvard. I came back because this way I can tell the story that I have been there. Otherwise, if I was still in Harvard, I couldn't tell the story to anybody. So actually the reason why I came back was because I had learned a lot of things there, but I would like to share those things with my previous and former colleagues in Italy. And so I decided that it has been nice to come back and make an all different experience, which is the neurorehabilitation experience, which is we started about 20 years ago, and it still is going on. So as you can see from the first slide, this is a picture that I took, I think 10 years ago, when with a few colleagues, a therapist, a nurse, another doctor, and so forth, we were smoking a cigarette outside. Actually, I quit smoking 9 months ago, Laura, so that's a good news too. And the reason why I took this picture, it was because I got the sense in that time that even when we were smoking together, we were doing something as a group, as an equipe. And this is the reason why I like this work, which I've been doing since 2001, because we work all together. Anybody of us is not enough for any patient and for any family members and for any other colleagues. So we need to work together. Why we are talking about the severe acquired brain injury and the post-coma patients here? Because as Laura said, this is a very long way to go. And if we want to explain what is the coma, we just have to do to have a look on this scale, which is actually the scale that provides us about the definition of coma, which is just staying with the eyes closed without no reaction to anything. And what goes on is just the autonomic function, breath, heart rate, and blood pressure. Most of the time, the coma in our patient is a spontaneous one due to the severe damage that we have in these patients, brain damage. Otherwise, the coma could be pharmacological, but in all of these subjects, what we have is that they are not able to respond to any single stimulus. As long as the patient stays with the eyes closed, the coma is still going on. In fact, the first thing that we ask to the family members, the relatives, whoever is with our patient, when did the patient open his eyes? At that time, the coma is ended. So the clear definition is that when you open the eye, you are not in coma anymore, okay? And so when we see the patient in our department, which is the Neurorehabilitation 2 at Fondazione Santa Lucia, we define them as severe acquired brain injury when the Glasgow coma scale at the entry in the emergency room or neurosurgery or whatever is lower than 8. Normal condition in this scale is 15. So you can see from this table that when we get very low performances, the worst coma could be 3. At 2 or 1, you are almost dying. So the worst Glasgow coma scale in these patients is usually 3. What defines also the severe acquired brain injury is the duration of the coma that must be at least 24 hours. But you consider that in our patient, usually the duration of coma could be also 1 or 2 months. So that's why we need to rehabilitate all the things that are not going, the functions that are not working, but also the fact that the patient has been in a coma state for such a long period of time. Of course, the patient doesn't know anything about that when he wakes up. This definition defines the so-called Code 75, which is an administration code, which defines the needs in this patient of high neurorehabilitation level. And our department is classified as a Code 75, so high neurorehabilitation level. This is what the patient looks like when he is in intensive care. Imagine the worst condition, which is the severe acquired brain injury due to trauma. Trauma is very often a car accident, but it's also an attempt to suicide. It's also victim of violence. Whatever it makes multiple damage, not only to the head and the brain, but also to our side of the body, sides of the body. You can see here that this patient has also a leg which is not, which is in a cast. And there are, I don't know whether you can see the pointer here. Da lì.
Di solito in piedi.
Yes.
Se riesce.
Ok, forget. Non so se appunto si vede, se la vedete. Sì, si vede. Ah, ok, va bene, allora se si vede sì, è che non capivo il bianco su bianco appunto. Ok, I was saying that the patient here has also fracture in the leg. As you can see, there is a cast here. But there are a lot of machines around these patients. He needs a respiratory support. He needs feeding through nasal tube. He needs vein or arterial access for drugs, for blood samplings, for a lot of function and need of examination during this period of time. Those are very critical patients. And one of the worst condition that usually, unfortunately, doesn't make these patients survive is infections. Hospital infections are the worst problem all over the world. Italy is not doing well in this sense because hospital infections like Acinetobacter and Klebsiella pneumoniae, when they contact, let's say, a normal subject, is not a problem. But if they contact and infect a fragile patient like these ones, so the problem is really serious. Most of the time, septicemia, general sepsis, and pneumonia are the reason why this patient unfortunately die. So the support and the controls of any single contamination through these bacteria or other viruses, of course, is very important to keep them alive. The brain injury due to trauma, as I was saying before, is mostly due to car accident. And you can imagine that we deal with patients to be rehabilitated, but as you know, there are a lot of deaths due to car accident. In fact, during the lockdown, during the pandemic, especially 2 years ago, the number of these patients decreased in a very, very significant way. So during that period, we had a lot of severe acquired brain injury, but they were mostly due to hemorrhages, for example, or serious ischemic brain ischemias, or one of the biggest problems was heart failure with anoxic encephalopathy. As you know, during the lockdown, a lot of people, they didn't go to the emergency room when they had chest pain due to heart attack because they were scared by COVID. And a lot of patients died or were seriously damaged by chronic coronary failure due to the fact that they didn't went to the hospitals. And we saw the secondary damage, which is the encephalopathy due to anoxia due to heart failure. So as you can see, when we talk about the pandemic and the cost of the pandemic during the year 2020 and 2021, we have to think about all these things because they change all the sanitary health condition. They have changed health condition, as you know. In Italy, we had to regain about, for example, 800,000 surgical procedures which were delayed during the 2020 and the 2021. So this is just to, to talk about global health that Laura likes a lot. So going back to severe acquired brain injury, we have to go through the acute phase, which is the intensive care and the neurosurgery. And those are the departments from where our patient mostly comes. Then we have the neurorehabilitation, which is the post-acute phase. Afterward, we have to deal with the long-term phase, which is usually how to continue the rehabilitation program once the patient is able to go home, or to provide, for example, extensive neurorehabilitation as a day hospital condition. There are also, depending upon the areas where the patient lives, conditions where a patient can be treated at home with the domestic services. Or there are conditions in which patients are from other cities and towns, so we provide sort of transitional housing. For example, we have Casa d'Ago, which is a place where people that have to use still our services as the hospital services, they are hosted and they go back and forth every single day to the department, have things done, and then go back to Casa d'Ago to have other activities in the afternoon, and they sleep and have dinner there. Unfortunately, not all patients are able to go back home, and not all families are able to accept again back these patients at home, especially when the sequelae are very serious. So we have to provide also some other condition and solution to these patients too. As we said, once the patient opens the eyes and the coma is over, we deal with a patient that we say can be classified into 3 different conditions. One is the recovery of consciousness. That is the way, that is the condition in which patient can somehow react to some stimuli. Even though it might be very primordial, very simple responses, but still the patient is able to do that. There are a condition, the opposite condition, which is the vegetative state, where the patient is with the eye open, his vigilance is there, but is not conscious of what is happening around him. So he may respond to painful stimuli, for example, but is not able to communicate in anyhow with the condition which is staying around him. And then we have a middle way condition, which is the minimally conscious state, minus or plus, which is a sort of midland in which patient in some moments is able to react and show some kind of consciousness to the things that happens around. But those are just islands of consciousness. In other moments, the patient is not able to do. For example, if I enter the room of this patient, during an island of consciousness, he may rotate his eyes to me, because somehow he notes that something is happening. If I do in a different moment of the same day, the patient is not able to do that. So he's not able to react to my entering the room. So we define this patient as minimally conscious state. And when the patient comes into our department, we use basically these three different evaluation scale, which is the Glasgow Outcome Scale, the level of cognitive functioning, and the disability rating scale. What these scales define is actually the ability of the patient to react and communicate with the environment, okay? You may find this online, so it's very easy to check for the GOS, LCF, and the RS scale, and you can find them both in Italian and in English. So those are, sure. Sì.
Sorry, may I ask you a question?
Sure.
When you have a patient with these islands of coma,
Consciousness, yes.
consciousness, not consciousness, unconsciousness, is it a problem, the relationship with the family?
No. I will go to through that a little bit later, because the family is very important there. Actually, familiar faces are much more interesting to this patient, and they may react even emotionally. I'll talk to you about this also regarding the pain evaluation, for example.
Yes, but for example, the hope of all the families is, okay, he has an island of consciousness, then, okay, everything is changing, and then tomorrow he will walk, okay? It's not like that.
No.
And then the relationship, she's very positive thinking. She's very positive. This is a way of life. But remember that they have to cope with these different realities.
Yeah,
is
but
it true?
reality changes. In fact, as when the neuropsychologist we observed that the patient has regained some island of consciousness, well, actually, we are happy because you can work on that, and the stimuli that you can give during these islands enlarge the islands themselves, okay? So we have to make sure that there are those islands, because sometimes, I don't know whether I can say this, but I will tell you. The Englaro story, probably you know the Englaro story. Since I have been working in Santa Lucia for many years, when I was working, I was looking at the videos with this woman, I could realize that there were probably some islands of consciousness, okay? So the decision to stop, for example, feeding and hydration in a patient which is, for certain moments, consciousness is very, very, very serious decision, okay? So it makes the difference in between the fact that the patient is not able to react at all, or the fact that the patient is able to react to something. So that means that if he or she feels something. We don't know what and we don't know how, but we have to take into account, since we talk about ethics, in my opinion, that the patient can feel something, even very basically. And we have to work with this in this small period of time and stimulate and open the windows as much as we can. So I know that those conditions cannot change, not necessarily change in all patients, but if we have a patient that enter our department as a vegetative state, and then it goes through a minimally conscious state minus, and then it goes into minimally conscious state plus, which is a further improvement, why should I stop there? I want to go further and make this patient have a full recovery of consciousness. Then there is all the disability that you will see in the video, but still we have to work on that, because we know that the improvement happen, not in all the patients, but it can happen.
No, I have a question about the famous Schumacher, okay?
Yeah.
I think, as far as I know, Schumacher is in a vegetative coma since years, isn't it like that? And who has to decide for him? Just family members, not to do anything to preserve him
well,
as
with
as a living cadaver?
that's a big question, of course, because the biological come si dice testamento? Witness is a big issue. Actually, until last summer, when we had to make a procedure on our patient, we asked the informed consent to the family member. That would be the wife or the husband or the mother or the child. But in Europe, things have changed. So now, if I want to take, for example, a CT scan in a patient that is not this kind of patient, but just is an Alzheimer patient, so with a low cognitive level, and he cannot decide by himself. The family relatives are not anymore legally approved. There is the need of administrative figure, which has to be chosen by the judge after an administration process, which is very long. So if I want to do a CT scan to this kind of patient, I, myself, Dr. M.G. Basi, have to sign up the informed consent according to the penal legal article 54 that this procedure is necessary for the patient. So let's imagine what can we decide on a patient which is in a coma state? Nothing. So if you have the biological witness, then that is something. But as a medical doctor, we know that we have to go ahead until the patient has a vital function that are just going on. It's very difficult to decide when and where to stop. Because, for example, for the vegetative state, the former definition was permanent vegetative state. Now we say persistent, which is not permanent. It's different.
Just to laugh a little bit, yesterday on a newspaper there was a case of a girl who, during the funeral, knocked out on the coffin, saying, "I'm alive, I'm alive," and then during the funeral, the people listened something, and then she was alive, and then probably they decided a little to quickly to put her to send her to a funeral, then a funeral house. Then sometimes it's not so easy to decide. Also, because sometimes we have some state not so clear, and then, but Professor Buzzi will explain you better.
Okay, going back to what we do there, just to be simple, as you can see here, the post-coma unit has a very large team of expertise. And this is all the figures and the instrumental needs that we use in our patient. I'll talk to you about some complication in our patients, and you will understand why we need all these people. For example, why we need the neurosurgeon once the patient is in neurorehabilitation. I'll show you. Why do we need the thoracic surgery? Why do we need all these eye specialty, the general surgeon, the whatever? I'll show you why. So the multidisciplinary team is not just a pure rehabilitation team, but is a sort of policlinico, as we say. We have a policlinico staff. Policlinico means all the possible clinics that are available. When you have this kind of damage, of course, you have a brain damage, which is something that completely destroys the equilibrium that is the normal life. Usually we don't think how difficult is the activities in the brain when we don't have any problem. We understand that when we lose the equilibrium and where all this, you know, this perfect harmony goes completely out of order. This is just chemical. When you have a severe brain injury, what it happens is that all the roots, the neurons, the areas are completely destroyed and lost, and all the chemical, which is the basic, fundamental of the brain activity, catecholamines, dopamine, serotonin, nerve growth factor, whatever you think, it goes in all possible direction, but not the right ones. So we need to restore the chemical and the functional role of the brain areas, even in those brains which have, of course, the damage, the wound, the remains of what has been an hemorrhage or a severe ischemic area or a severe traumatic injury. So we need to restore a condition which will not be the normal one, but will be something that will try to perform close to what was the normal one before all this happens. So we have to work on all the possible function, which is the cognition, first of all, because if the patient is not aware of what are the disabilities and the deficits that he has, he will never work as in a way that is good to go further, to have a progression in amelioration of deficits. If the patient is not aware, it's very difficult to do neurorehabilitation. That's why we call it neurorehabilitation, because we need to go to regain, first of all, the cognitive functioning before going through the motor, the equilibrium, and so forth, because you can have a very good motor performances, but you have to know where to go. That's the problem. So what we do, what the doctors usually do inside this rehabilitation program is to make a program for the rehabilitation itself, but also to work with the pharmacological tools. And this is really very important, because we have to provide with our pharmacological tool a lot of things. We have to reduce, for example, and to solve the problem of infections, because most of these patients, when, as I said before, when they come to us, they are not clinically stable. Most of them, they still have infections. So we start working with antibiotics, for example. They have agitation and vegetative syndromes, so they go to 150 heart rate to 250 blood pressure. So we have to work with the blockers, antihypertensive stuff. They are agitated, so we have to work with drugs that reduce agitation, but in a way that the patient is not sleepy all the time, because otherwise he will not perform any rehabilitation program. So as you can see, the pharmacological tools are very, very important, as well as the monitoring of all the functions that have to be checked continuously. So we have in most of these patients, especially in the very few days, the beginning of the stage, all the machine attached as in intensive care. Another problem is, for example, the anemia.
Excuse me.
Sì.
This is a bad habit of this conference lecture to interrupt the speaker.
No, I don't care. It's fine for me.
No, if we go back, just now you are explaining how to rehabilitate, okay? But let's come back to the decisions.
Yeah.
So let's imagine something which has really happened in the last 2 years with COVID, okay? My mother is in intensive care room.
Yeah.
She's in coma, okay? And we have to, in coma, it is possible to, in some way, to come out from the coma. She is in the stage in which it is possible, we can hope to have some kind of recovery, okay? And the anesthesiologist says to the son, okay, maybe we can manage that your mother can stay alive. And the question of the son is, but in which conditions? Well, your mother will maybe survive, and okay, she will be disabled forever, and she will no more be self-sufficient. And so the next question I think the anesthesiologist should make to the son is, how was life expectancy? What did your mother expect from her life? Was she, do you think that she would accept such a kind of life? Well, is there any space for this kind of discussion or not?
I think I don't work in intensive care unit, so I cannot say in person, but I think that there is, but still I believe that the doctor, medical doctor, they usually try to, to keep in mind that if they can do anything they want to do. And about the expectancies, not all people have declared in their life what they would like to be done in such conditions. That's why there is a big talking about the biological witness. What would you want if in the case that? Because I don't, for myself, I think with my father and my mother, we never talked about their own decision in this case, but I'm sure that when my father was very sick and he was again going back to the intensive care unit, I'm sure about that. He told the anesthesiology, don't go further. He decided in that very moment, but he was awake and he could say that. And the doctor told me, and he said, you made it right. If you didn't do anything because he asked you in that moment and he was awake and safe in mind, you made it right. I agree with you and I agree with my father. Then he died. But he decided that he wanted to die because he understood that his personal expectancies would be, as you said, a disabling life without any ability to do things by himself if he was going to survive after, some critical procedure. But he could decide at that very moment. And I think that nobody is able to do that. it can be that. I don't know, Laura, if you have any experience about that.
In my experience, because my first specialization is resuscitation, an anesthesiologist is also a resuscitator. Of course, it depends a lot on the patients. It depends a lot on different moments of life. For example, for young people, nobody usually has the courage to say stop. No, for young people it's impossible. 1 month ago in a clinic in Rome, in an important a private hospital in Rome, there was a young girl. She had a car accident, very important car accident. She lost enough part of her brain, okay? The family decided now is Santa Lucia, this girl, and then the family decided to make everything. But it's obviously that the quality of life doesn't exist. Of course, she can't change her status, but the family decided in this sense. But there is, for example, the father of Gabriella. She was very honest with you because she was talking about something very private. Okay, my father is on another position. He wants to do everything till the last moment of his life. It's not important the quality of life, but to live is better than to die. Okay? Then I think that you have to respect the patient. The first thing is when you have a case in front of you, to respect the patient, and then to respect the idea that everybody has a Weltanschauung system, a personal ethical system. For example, this is a course of moral philosophy. If you don't think that there is another life after, it's difficult to lose it. Of course, it depends. It depends, and I think that the difficult thing for people is to cope with different way of life, different thinking.
There is also something else to say, that patients that go to a big car accident and a coma and survive from this, they are not very old, because the older they die, they are not able to survive such a big trauma. So the question goes around people that are not so old. So as Laura says, I wouldn't dare say to a 20 years old boy, stop everything. Even because we have patients that adhere to us as a vegetative state, and then they graduated as a lawyer or an architect, and they are back to work and they got married. So, you know.
But the problem is if you have lost a part of your brain, enough brain, this is the problem. Because, for example, for this girl, during the car accident, after the car accident, she was operated, and then they decided to put a plastic, something like a cover in plastic, but there is nothing inside, okay? It's wide. And then it's completely empty inside for enough part. And then it's difficult because she's living, she's breathing, she can do something, but the second question is probably we don't know enough to decide for someone.
Well, I'll tell you another story. This is very tough. We had, she was on the newspaper, so I can tell her name with no problems. Chiara Insidioso Monda. She's a very young woman, and she was victim of violence from her boyfriend. She was almost dying because of this knocks and whatever was the violence, but she didn't die, okay? The boyfriend himself brought her to the hospital. She stayed in coma for 8 months, okay? Then she came to our department. We made the best we could. And now she communicates with a finger or with lip movement. She sits, she can eat by mouth, and so forth. Of course, she doesn't do almost nothing. She doesn't have any social life. But I'm glad that Chiara Insidioso Monda is still alive, because she's a witness of the violence. And in fact, she's has been on the newspapers, and her boyfriend got 16 years in a jail that were reduced to 14 years because he didn't kill her. So Chiara, she has to live as much as she can, because she has to witness this condition. This is to say that everybody who survives has a role, in my opinion. Just, you know, to answer to the question of my point of view, I think that any survivor has a role.
From an ethical point of view, this is a very, very interesting point. When you are a witness of something, you can be the first point of a change. In the sense, for example, we can talk about DJ Fabo. DJ Fabo decided to leave because he decided at the first time, if you participate in the future, if I will participate to a conference with the girlfriend of him, okay, she decided to support him. They make a trip to India, and then they decided a lot of things. The last, at a certain point, DJ Fabo has of course realized that he can't see anything, okay? He realized that not to see, not to have the vision, it was too much for him, okay? And then he decided from this point to make a suicide, etc., etc. You know the story, but he changed a lot of things. We have a law now in Italy because he decided something. If the DJ Fabo didn't decide to survive, but for example, he decided to take some pills, helped by his girlfriend. Okay, we didn't know. Of course, we couldn't have a new law to protect people who decided to make suicide. Okay, I don't have any judgment of it. Okay, because of course, in my point of view, is too difficult to think to the suicide. But anyway, there is a law. And then, if you decide that you want to use this law, for example, in ALS people, as yesterday we have seen with Professor Rineburger, they have the possibility now, because he was a witness. Then I think that it's a big weight on the shoulders of these people, but to be a witness of something is to be also the promoter of a change. Okay, thanks. Professor Boccanelli.
I have a question for the audience. Okay, did anybody of you make advanced treatment provisions? You know what I mean? Did you write somewhere what doctors should do in case of you were in the conditions of Chiara, for example. Did anybody did that? No. I think it is better to do that because we have a quite embarrassing situation. But let's imagine that Chiara had written an advanced treatment provision, and something should have changed or not in the behavior of doctors.
Well, probably yes. But we still have the, let's say, the caveat that when Chiara, or if I write it now, I'm in a normal condition, but can you swear to God that I would decide the same if I was in those conditions? That's another, that's why it's not easy. Because otherwise, if you make a law and say everybody has to write down what he wants to be done in the case of, that's the law. Everybody does it, and this would be the easiest, right? Just to show to wash your hand and forget about. But I know that it's not easy to ask everybody because not everybody has the ability to think this very big issue,
Shared decision making and team working, which is, as you have just heard, is very important in every kind of situation we work in our hospital or in our health profession. So please come to that lesson because there is a cardiac surgeon and two CEO of big industries.
Do you remember the first time we met? We have discussed something about religion. Okay, my first question was about religion because in your system, in your philosophical system, one of the biggest problem is, of course, if for example, if you are Catholic, how you can cope with the decision of suicide. Okay, it's very difficult. It's the same for abortion, but it's not only for abortion or for suicide, and it's not only for Catholic people. Is if you are religious, how you can cope. Now you have a matter of discussion, a matter of reflection on it, because of course in your professional life you can have this problem, and then you have in front of you patient with a completely different conviction from yours.
Well, this is true, but that you have to cope with the condition according to your spiritual, let's say, ability and so forth. That's why even in the hospice, the spiritual support must be, it's mandatory, for example, to decide the end of life way. But still, we have also to comply with the fact that when we are in a critical condition, it's difficult to go back to our spiritual, let's say, ability. Usually we think in a very simple way, survive or not survive. If I am under a bomb, it's very difficult that I start thinking God and so forth. I just have to run away or decide to die there. So that's why the decision-making process is very important and must be done with a lot of, with a very large keep that has to take into account all the possible situation and has to be done even in the light of the spiritual background that everybody has. Of course, you cannot do in a critical condition. That's very difficult to me. For me, it would be impossible to go back to my spiritual background if I had to take a decision for myself to die or to live. I don't know. I'm not so strong spiritually. This is what I think for myself. So I'm happy if other people can do that. I would not be able anyhow.
I think that in a team, for example, when you are you are working in in a resuscitation group, a resuscitator group, of course, you have to make decisions. You have to make decision. It's the first test at the beginning of your work. You have two people. Professor Boccanelli told you once, if you have two people, one younger, one older, you have just one machine to support the breath. What do you have to decide for older one or for the younger one? But you have to take a decision because you can't put two people with one machine and then at the same time, but you know that one of these two people will die. Then I think that this is for this reason it's very important. I'm sorry, Gabriella. To be stronger in the sense you have to think in advance. Okay, what do you want, which is your limit. For example, we don't discuss about our limits as doctors, but this is one of our problems. For example, why usually doctors don't like to take care of their parents, of their relatives, because this is a limit. Of course, my perception could be not so clear. I have in front of me my mother or my father. Okay, but this is a limit. I have to know before, not at the last minute. Okay, I have to think now. No, this is. I think this is the necessary background to work in this field.
Yeah. Well, the same applies to the neurorehabilitation access, because if we have two requests, one for a 20-year-old boy and one for a 70-year-old man, of course, and if I have just one bed, I will take the boy, because there are higher possibilities of recovery, obviously. Because I'm showing here, while talking, a lot of conditions that we have in our patients. Of course, all these conditions can be better treated in a young boy. Because if, for example, I have a car accident in a 70-year-old man that, for example, has a degenerative disease, his cognition are not so good even before the car accident. I cannot, think that I can do a lot with this subject. In a 20-year-old boy, I know that I can do a lot, especially if he was a clever, smart guy. So I go directly to the best condition that I can treat. Of course, it's easier to decide for me in this way. Usually, older people, they have already other pathologies like hypertension, heart disease, and whatever that makes these patients less responsive to the rehabilitation. Sometimes I cannot do things to older people because they cannot afford high efforts, for example. So if I have a patient with a heart problem and that can do small, low-level effort, of course, my work is limited. So I go directly to point to the younger one. The younger one also, going back to the pharmacological approach, is the one that best respond to drugs. So an agitated 20-year-old boy respond much better to quetiapine, for example, than a 70-year-old man. So, I have to make a sort of balance. And the first step is the one that Dr. Pacifici was saying in the resuscitation room, but the same applies to all the other disciplines. For example, if you have two patients waiting for a liver donor, that's the same. Who is the one that is going to receive the organ? If you have a 71 or a 21. This is a decision-making process that applies every single day. This is the very basic matter of the ethical part of our work. Dr. Boccanelli, I knew that you were going to.
I agree in part.
Let's see. Let's listen to the other part.
Okay. If you have to make a choice, if you have one machine for two people, you must have some criteria. But be careful to the concept of ageism, which means the discrimination based on chronological age. So it's not true that because I am 80 or 85, you should deny something.
No.
You should evaluate very carefully the conditions, the probability of survival, the probability of ameliorating, and this is teamwork, of course. This is true, for example, in cardiology, in cardiac surgery. You have to decide if you put a heart valve in an 85 or 90 years person. Well, okay, you should know everything about frailty, about disability, about way of life, and so on. So it is always a matter of a very careful attention made by a team to take decisions which are so delicate for the choice.
Sure, you have also in this kind of fragile patient to take into account also the risk of the procedure itself, no? It is a part of the, no, or not, because you can have an 85-old man which is very healthy, and so he can survive an operation much better than a 50 years old one that has a lot of clinical problems, as you say, to evaluate every single thing beside further than the age, of course. What I was saying about the age was not that I would discard the older. I would say that if I had to make a choice, taking into account a healthy 20 boy compared to a 70 sick man, of course I will make this kind of evaluation that you are saying, and then, you know, match which is the best, which is the one that will receive the only available tool that I have with myself. There are also 20 years old boys and girls that have very, very important diseases, and that makes them unable to receive some treatment, of course. So in that case, I have to choose in another way, because unfortunately not all the young people are healthy. This is another problem. Bye.
If we want to make a comparison with yesterday, if you want, we have talked about chronicity. Today we talk about coma, post-coma. There is something in common between these two lectures, these two topics. But with chronicity, you know that chronicity has, with the last point, the worst condition of the person, okay? And then for post-coma, you have more guess, okay? You have more possibilities. If you want, during a period, they stay together on the same rails, but they don't do exactly at the same, they don't join the same point. For chronicity, anyway, you can't improve. You can only decrease your quality of life. This is the only thing you can do. The decrease to the quality of life. For post-coma, you have to improve your quality of life and to make a good rehabilitation, and then a lot of things. Then there is something in common, but the final points of arrival are completely different, okay? Take in consideration.
Yeah, in fact, what we, as we define these patients is the long-term disability, not the chronic disability, okay? Yeah. Chronic in this patient could be, for example, epilepsy, which is a complication of even after months, a complication of severe acquired brain injury damage. But as all epilepsy is a chronic factor, but that does not mean that the patient cannot do a normal life. For example, with some residual disabilities, we know that the equilibrium is one of those that continues to improve during all lifetime. So we would, when the patient say, I still have to walk with my foot, large bases and so forth, don't worry, because this is going better and better. So it's going to improve, even though you will not do any more neurorehabilitation exercise. But there are deficits and disabilities that continues to improve anyhow. So we have to take into, and also another important thing is that when the patient goes back home and take back his own things, friends, study, playing PlayStation, whatever it is, that's a sort of neurorehabilitation too, and is very ecological and is much better than doing neurorehabilitation in the hospital, for example. That's why at a certain point of the project, we say to the family, please bring this guy at home. And then we will continue in other ways, like the hospital or outpatient or whatever. We continue to do neurorehabilitation, but we need to put in the rehabilitation project also the ecological condition, which is home, which is friends, which is going out for a pizza, which is going out for a stroll, whatever it is, the normal life, because the normal life gives different inputs. And when we take this patient for a too long period of time in the hospital, we are taking off from their life very important thing. This is a sort of ethical problem too, because most of the time the family says, well, but we have to finish the project. The project never finishes. As I said before, the rehabilitation process is for a lifetime. So we cannot keep these, especially young people, in jail in our hospital, rehabilitation hospital, because we want them to go back to their lives and challenge with that, because when they continue then to do, for example, outpatient cognition therapy, they talk to the therapist and says, well, when I go out with my girlfriend, I have these problems. When I do mathematics, I have these problems. When I, for example, contact my professor, I had these other problems. So, and the therapist help the patient to improve on those specific failures that he or she has found in the normal life. So the normal life is a big part of the neurorehabilitation, and is what we want to do as soon as possible in our patients. Of course, we have to bring our patients in a condition that is that the family can work with that. So, for example, patients that are able to walk, even if they use some deambulator or whatever, but we have to keep them as independent as possible, because the family has other things to do. They have to work and so forth, but the family and the house and all the outer life is really something that helps to improve significantly the rehabilitation in our experience, but not only ours. Of course, when we receive these patients that are not able to swallow, they are fed by the nasal tube or the PEG, we have to finish this project of rehabilitation of dysphagia in the hospital, because it's a very tough problem with the family. And in most of cases, we bring our patient to feed by mouth in all the cases. So we remove the PEG, the nasal tube, the tracheal tube, and all this stuff that must be, removed as soon as possible because of the infection, because of the pain, and because you have to give to the patient is a normal way of feeding and of breathing. there are conditions in which we have a lot of complications. For example, the tracheal stenosis. We have to make sure that when we send the patient at home, this complication would not happen. So that's why we need a lot of control, and as soon as we have problems, we refer to the thoracic surgeon, Professor Rendina, and all the team. I remember that when I was in Harvard, by the end of the 80s, people that had tracheal stenosis following the intubation, they came to Boston, and I was used to host some member of the family in my house because they came to the Mass General Hospital because in Italy nobody was able to do surgical procedure to reduce and the tracheal stenosis. Professor Rendina, Erino, came to Boston 30 years ago, and he learned how to do, and now is one of the referring thoracic surgeon in Rome and in most of Italy. Also Galluccio at San Camillo is another one. But we are talking about by the end of the 80s, is 30 years ago, it's not so long time ago. So this is to say that we have learned a lot of things. And now nobody dies for tracheal stenosis. In the past, people were dying because as long as they started to tirage and just a small part of area was passing through, then the trachea collapsed and the patient was dead. There was no time to fly to Boston and have the intervention done. So,
take in consideration that when I checked on PubMed before coming here today, one of the last article is severe tracheal stenosis after prolonged intubation post-coma. Then it's a problem very, very common also now, but of course, there is something a little bit, she's very positive, I told you many times. And then there is something a little bit romantic in the profession of a doctor. And then we have the idea a little bit as Cinderella, to have a pumpkin and after some few minutes to have a carriage. Okay. This is not a carriage. We don't transform a pumpkin in carriage, okay? Take in consideration, we can change a little bit pumpkin in something different, but not pumpkin in carriage. Because when you think, I go back to your idea to make surgeon. Surgeon is a very salvific experience of medicine, and then is more related to the history of Cinderella and the big change of Cinderella pumpkin to carriage. But honestly, we can't do miracles, okay? Taking in consideration that you can have step by step some little improve, they can improve, these patients can improve step by step, but in a long time.
Well, I'm positive, yes. And in fact, I want to say to the all of you that want to be surgeons, that for example, in the case of orthopedical surgery, we may give back a good function to a leg, just removing pararticular ossification, which sometimes are big like apples or cucumbers or melons or whatever, and they do not allow a normal movement to, for example, to an ankle, but the orthopedic surgeon is able to remove the ossification, which is a complication of prolonged staying in the bed, and give back a function to a patient. So I'm positive, yes, I'm positive with the tracheal stenosis, I'm positive with the hydrocephalus. Hydrocephalus is a not rare complication of severe traumatic brain injury, and is when the system, the CBF system is not able to absorb back the cerebral spinal fluid which is formed, and this become a big volume inside the head, and you have to ask to the surgeon, yes, I'm positive, because of this, to the neurosurgeon to put a system that drain this excess of fluid inside the belly. And that is possible. And there are a lot of people that have this system in the head, draining in the belly, that have a very normal life. So the hydrocephalus can be corrected. And when the surgeon put back the cranioplasty in a patient that in which a part of the bone has been drilled out because the hemorrhage was too big to be contained in the closed cranium, and then he puts back this piece of bone, then the patient regains a lot of functions. So when we ask the surgeon to put back that piece of bone to do the cranioplasty, we do that because we believe, and we have seen that, because we have seen that after the cranioplasty there is a further improvement in our patients. So I have some reason to be optimistic, otherwise I wouldn't do this work, but also because I can see the results of surgical intervention. But not only the surgeon. Now we also use the team of the psychologist, for example, from one side to have the cognition assessment, but also to support our patients. And there are patients that go into depression because of their disabilities. But this is not always the case. We have also patients that are apathic, they have inertia, which are psycho-organic syndromes, which are due to the damage of the brain. And again, we go there with the drugs, but with reactive depression that is very frequent in patients that have regained very good quality of life, but that have still disabilities. We have the support of the psychologist. So psychologists are a very important part of the team, especially in the later phases of the rehabilitation program. As I said before, we can have symptoms and conditions that last, but those are easy to be corrected with drug, like epilepsy or pain and so forth. This is something that bothers the patient mostly because he has to take the drugs, but it's possible to control this condition, and this is again an important role on the long term, in the years after. So that's why we dedicate a post-coma ambulatory outpatient service to all the patients that leaves our department. We follow them up for years to take under control some condition. And then we take care of the sleep of the patient, because when Laura was talking about the girl where a big part of the brain was out, we have to take into account that the brain has to control the sleep, to control neuroendocrine system, to control the response to infection. So of course, if I have a big damage of the brain, all these functions are altered, and I have to work on that. The sleep also is the sleep disorders are very often in our patient, because when they come from the intensive care unit, where always there is artificial light, they don't know when is night or when is daylight. There is always noise of machines, nurses and doctors which are going back and forth 20 hours a day. So that is a very disrupting condition for the sleep itself. So when the patient came to our departments, usually they are not able to sleep anymore. So we have to correct this rhythm too, because if we don't correct the sleep, the pain it's even worse, the agitation is even worse, the pressure is even worse, the heart rate is even worse. So as you can see, everything is entangled each other. Any single function interferes with all the others. So we have to play on all this to correct all of them. And this is a very important thing that you have to keep in mind. This is just to talk about the pain, which is another thing that is very important and sometimes is not so taken into account, because patients are not able to testify their sufferance because of the pain. So we have to find out some way to disclose where the patient has pain or not. For example, we found out with a study that we have done in our department that if you try to identify the stimulus that gives pain to that patient, for example, a nursing procedure or a physiotherapist procedure, then you understand that these people, even in the minimally conscious state or their vegetative state, they have a reaction to pain, but you have to observe the patient. So if you understand that there are maneuvers that give pain, then you have to treat the pain, because the patient suffers, even if he's not able to tell you that he suffers and how much he suffers. So we have to provide, now probably you know that since 2010 there is a law in Italy, which is the one that makes the recording of the pain mandatory in the clinical paper. And it's mandatory to record, to register, and to treat the pain. This is law. So we have the law of trying to identify whether a patient is suffering or not because of pain, to treat it and monitor accordingly. And of course, we realize that as soon as the cognitive function improve in these patients, also the ability to express their pain improves. And of course, it makes it easier to treat this condition. In our department, we are recently trying to use also sensors to identify responses of any type, but the basic one that we are using recently, and this is very interesting, is that we can adjust the personal project to any single patient for any function, and this is something that we have done recently for the equilibrium in patients that regained let's say, very well, but still they have some equilibrium problems. And we have created this sort of figure of 8 walking, and it seems a silly idea, but actually we were used to rehabilitate equilibrium on a straightforward, let's say, come si dice, passeggiata, walking, okay? But that is easy. If you try instead to rehabilitate the patient in a sort of figure of 8 like this, you can see that he has a lot of problems in carving continuously. And so you rehabilitate the ability of carving, not of walking. And rehabilitation of carving is a very basic part of the equilibrium recovery. So we have published a lot of things with this because we work with the University of Foro Italico, which is the former physiotherapy school, and they are engineers mostly, and they do produce this kind of sensors that can provide also feedback to the patient and you know, have him or her aware of the problems that they are getting and how to correct them. So finally, what we need is this kind of equipe. But going back to the initial question about the family is very important to us, part of the legal stuff that we have discussed, because from the family we know what Professor Boccanelli was saying before, if available. That is, how was the subject, what was his life experience, the expectation, the belief, the whatever we can get is very, very important. The other part is that the presence of the family, of a family member, the closest one possibly, gives a higher possibility of reaction to these kind of patients, and is very, very important. In fact, we had a lot of problems during the lockdown period when no family member was allowed inside the hospital. It was really sad. So we had to provide, you know, a sort of, how do you say, you have to make ourselves being family members and friends and relatives of our patients, try to take the place of the family, but of course this is not possible. Also, the family serves for a lot of procedures, that is how to ask for presidiums to the sanitary system when we have to send the patient back at home, like the chair, the bed, all the stuff that he may need. And also in the prison society, the family for us is very important because we have a lot of foreigner patients. So we need also the cultural mediator, and of course the family member is one of those. Especially young people that are born in Italy, but of course relatives that don't speak Italian or speak Italian very badly, they serve as very good mediators, and young people now are the real bridge with this to the different culture. They also knows about the spiritual believing, which are not the same of us, for example, no? Because we have a lot of Muslim, Hebrew, all different possible religious background, and it's very important for us to have this support from the family members. Casadago, I told you before, and the family member most of the time are those people that suffer the most, and unfortunately sometimes family members, they run away, especially the husbands. The husbands are those who really are not able to keep the situation. The mother are the last to abandon, I must say. So if we have a range of ability or disability to take this condition among family members, I would say that the husbands are the worst and the mothers are the best, generally speaking.
General speaking, and then without any comments.
For this reason,
husbands are the worst. Remember, for young girls.
For this reason, we also have the psychological support for the family members, which is in our department is a service that is offered to anybody of the family members or relatives or friends that ask for this support. And not all the members apply for this. I must say that the usual thing they say is, I can do it by myself, which is not true. Because as we say them, the batteries go down, and when you have to recharge the batteries, you need the support of the electricity. So the psychological support, when they accept it, I must say that is very, very, very useful. Also to prepare for the future, the long-term life that is going to involve the patient and all those people that will be around him or her as caregivers. Okay, so I think that most of the things that I've said are done. So for now, I wish to thank you, but I want to show you a video which is...
Dove l'avevamo messo? La cartella
qua.
Esatto, clicchi e
Era
quello là.
questo?
Un attimo prima che lo mette che avverti i ragazzi. Quello lì Michele. Sì, esatto, un attimo prima.
Sì. I'll show you Michele. Per lo streaming devi applicare per quelli che seguono da fuori. Perché? Vado. Come l'allarghiamo il...
Scusi,
Prego.